What's up, Ninja Nerds? I am excited to be here with you guys today. Today is going to be the 18th case study, and I know it may sound sad, but this will be our last case study. Now, hold off before, let me explain. The reason why this will be our last case study is that today what we're actually going to try to do after today is move on to podcasts. So we're really taking that big step into going into podcasts. So the next podcast is going to be starting, hopefully I'll start working on these topics that are particularly more clinical oriented, give you the very most important evidence-based medicine approach behind how to treat patients, how to diagnose patients, what are the most important clinical presentations, what is the most significant pathophysiology that you need to diagnose, to treat, and think about how to be a better practitioner for your patients who have these various conditions.
Zach, flip your hat around backwards.
Oh, okay.
Thanks.
So again, we're going to be kind of doing that starting, hopefully, my first topic that I'm going to work on the podcast is actually going to be cardiac tamponade. So I think that'll be a pretty cool one. I've seen it a couple times, and it's a very scary situation. So what I plan on doing is taking and diving into the literature and providing as much information as I can that's evidence-based, that'll give you guys the most important things that you guys need to know as nurses, as PAs, as doctors, and even as students who are interested in learning and getting a little bit more prepared for whenever you walk out there into the clinical world. So I'm really excited about that, and I'm really, really hoping that you guys will like that. So stay tuned. We will definitely keep you guys up to date. I think the first podcast topic is going to be with me and Rob, and we're going to be starting on cardiac tamponade. But until then, let's finish up our last podcast in style. And let's talk, our last case study in style, and talk about myocardial infarction. Okay? So, first things first, what do I really want to talk to you guys about today with the myocardial infarction? So one of the things I think that's really interesting is talking about post-MI complications, right? So we'll have a podcast that's actually dedicated to how to diagnose, how to treat particular type 1 MIs. We'll get there. But today what I really wanted to talk about was a very quick, bare bones approach to how to, diagnose, treat those post-MI complications, okay? So my question for you guys is, hit me with your best shot, some couple post-MI complications that are really, really important to know. So once someone's had a significant myocardial infarction, right, whether it be an anterior MI, posterior MI, inferior MI, whatever it may be, they've suffered a myocardial infarction. What are some of the big post-MI complications that you can see in these patients that you should be thinking about in your differential? So hit me with a couple of those particular types of post-MI complications that are very concerning and you want to be thinking about when you're trying to diagnose and treat a patient who's presenting with some odd symptoms after having a post-MI. What are those things? Any of you guys know? Pericarditis, Dressler syndrome, mitral regurgitation, Ramea said. I love it, definitely. Aneurysm, so left ventricular aneurysm from lots of lettuce, absolutely. I don't know what anterior diarrhea means. Ventricular rupture, I don't know if that's what she meant, like your left ventricle just explodes and pops blood into your pericardial cavity, but yeah. Cardiogenic shock, arrhythmias. Yeah, so as you guys can tell, you guys are definitely right on point that there's so many different things that can happen after patients. And then, Zoe said a stroke. Yeah, you can definitely have an embolic events after having an MI. Okay, absolutely. So here's the most important ones that I think are very significant to be thinking about as a practitioner who you're out there, you're seeing a patient who's just had a myocardial infarction and they are at risk for what types of complications. These are the ones I want you to remember. So the first one up that I've seen a couple times, and believe it or not, it's not actually mentioned too much in some of your boards literature. It's more particularly clinically that I've seen it. And this is a retroperitoneal hematoma. And so what happens with retroperitoneal hematomas and what they are is whenever they're going in to do the catheterization in the cardiac cath lab, they have to access an artery. And usually the more common one that they access is like the femoral artery. You can use the radial artery, and I think the radial artery is better in those situations. But when you go through the femoral artery, sometimes you can just backwall it, you can puncture it, and then you can allow for bleeding to occur around that arterial area. And so because of that, you can develop pretty significant amounts of bleeds from that deep femoral arteries that can actually splice backwards and into the peritoneal cavity, and it can cause a massive amount of blood to accumulate there, a lot. And these can become very quickly hypovolemic or hemorrhagic shock patients. The other one is post-MI pericarditis. Again, be thankful if you ever see post-MI pericarditis. That's going to be kind of like the least of your worries. A reinfarction is a pretty scary one. It's also very difficult to be able to diagnose. Any kind of mechanical complications that you can see post-MI, usually after about anywhere between the 3 to 14 day range, you may see things like a papillary muscle rupture, which can produce like an acute onset mitral regurgitation, a ventricular septal defect from a septal wall rupture, and then a Freewall rupture, which is definitely scary and will make you poop your Huggies. The other one is you can definitely see some tachyarrhythmias. You can see AFib, but the one that really, really is scary and will make your sphincter pucker up is the Vtec and VFib. So radial greater than femoral because less bleed risk. Absolutely, man. Hashtag radial first, baby. Bradycardias. So bradycardias, definitely get some heart blocks in some of these as well. Okay. And lots of lettuce said that's why you have to access below inguinal ligament. Yeah, and it's true. Sometimes you can get like a deep of the profunda femoris during those time periods, and that can actually cause a decent amount of bleeding. But yeah, it just kind of it depends. It's unfortunate kind of complications that you can see in these patients. But yeah, I prefer hashtag radial first. You definitely don't get a lot of those complications. Okay, so let's talk a little bit about retroperitoneal hematoma. These are very interesting complications. So usually you'll see this not too long after someone's had a cardiac catheterization. So let's say that they got their cardiac cath, they came back to the the ICU, and they're being managed on all of their supportive care measurements and continuing your infusions or whatever it may be for this patient. Usually what happens and how they'll present is generally the patient may have some type of onset hypotension. So their blood pressure may start kind of getting a little bit slower and a little bit lower. So generally what you may see is some new onset hypotension to the point where maybe you're having to give some fluids, maybe you're having to start a pressor on these patients. And they're the worrisome thing is that they can progress quickly though from just some low hypotension to getting into the point of vasoplegic and refractory hemorrhagic shock. And so that's kind of the thing that you want to think about. So if you have a patient who's coming back from the ICU, their blood pressure requirements are getting a little bit higher, you're having to start some pressors, they're getting a little bit softer in their blood pressures, go taking a look at their exams. Take a look, stand at the side of the bed, look to see if they look pale, look to see if they have cool, cold extremities, look to see if they have decreased pulses, and then take a look at that hematoma, take a look at the actual growing area, and see if you see any palpable hematomas or any visible hematomas that are near that area. Ask them if you have any pain near the groin, in the abdomen, pelvic area, flank. These are very, very important things. And then what I would do is if I see a patient who comes back from having cardiac cath, they're a little bit softer in their pressures, they have an obvious hematoma, I'll send off a CBC. And if I see a hemoglobin drop that's significant within that time period, that interval change, I'm going to be a very, very high alert of this patient having a retroperitoneal hematoma. Generally, the best thing to do for these patients is to get a CT angiogram. This is going to be the best study that you want to get. You can do certain types of ultrasounds to look for like a pseudoaneurysm, but the best test is going to be a CT angiogram. The reason why is there's two benefits. One is it'll actually show you the retroperitoneal hematoma, but on top of that, it'll show you the vessel that's actually extravasating, and that's important because that can guide the type of management that you want. Do you want to go in there and open up the belly, or do you want to actually go in IR-wise and put in like a coil embolize it or put it in a covered stent? So those are the big things that you want to be thinking about. Okay. Second thing is after you've gone through and had this patient, again, diagnosed via CTA, you want to start kind of getting ahead of the issue here. So again, their problem is they're bleeding. They're bleeding into the retroperitoneal cavity, and they can accumulate a lot of blood into that abdomen. And so what we want to do is we definitely want to stay ahead of their CBC. So usually what I try to say is that in the literature actually will say maybe go up to about 2 to 4 units ahead of whatever your goal is of these patients. So you really want to stay ahead. Don't get behind within their actual their hemoglobin and hematocrit. Stay at least 2 to 4 units ahead from what the literature suggests. Generally, here's my kind of look at this. If I have a patient who has a retroperitoneal hematoma, their CBC shows a hemoglobin drop, their blood pressure is getting soft, I'm starting pressors, I usually activate the massive transfusion protocol. So generally what a massive transfusion protocol is you're getting a lot of blood coming to the bedside, usually in one of those like, coolers. And so you'll get a lot of things like red blood, so packed red cells, you'll get what's called FFP, and you can also get platelets from there. And so what I generally will do is if I have a patient, I know they have a retroperitoneal hematoma, I've already diagnosed it, their blood pressure is getting soft, they're starting to go into shock, I will start off with a 1-1-1 and then an additional potentially 1 ratio. So that means 1 of packed red cells, 1 of FFP, 1 of platelets. And then what I'll do is I'll check what's called their fibrinogen level. If their fibrinogen is less than 150, that usually is a telltale sign that they need something called cryoprecipitate. And I'll give them some cryo. And usually this is my kind of go-to. This has kind of been backed up a lot by some of the literature. So that's usually what I'll do. Yep, Adrian said that perfectly. 1-1-1. That's kind of my go-to. And I'll add on an extra 1 for their cryoprecipitate if their fibrinogen level is less than 150. Okay. Would a fast suffice? A fast is kind of good in the sense that, so what a fast is really good. They're not really good for being able to tell you like the actual diagnosis. They're not good at diagnosing these. They're just telling you that you either do or do not have blood within the abdomen. It's not good at diagnosing a particular patient who would have some type of retroperitoneal hematoma, because usually with the fast exam, you have your different views that you're looking at, right? So you're looking in the right upper quadrant, you're looking in the left upper quadrant, you're looking near the area of the bladder. And so generally in those times, you're not going to be getting, and then obviously you have your subxiphoid view, but with those situations, it'll just tell you it's, okay, there is potential blood, but if there is no blood, or if there is blood, you can't tell you, oh, this is definitely a retroperitoneal hematoma. It can't tell you that this is a liver laceration. It can't tell you that it's a splenic laceration. It can't tell you that you perfed your bowel, whatever it may be. It just tells you if there is blood or if there's not blood. Okay. And so Ashley Johnson's asked about cryo, ? So cryoprecipitate is basically fibrinogen. And so generally fibrinogen is definitely helpful to be able to stabilize that fibrin mesh and help to basically induce clotting in these patients. So that is kind of the way. Yep, and Adrian said it very beautifully, fast is sensitive, not specific. Yep, so it just tells you, if there is blood, okay, that's all I know. I know there's blood in the abdomen, but I don't know what's the cause of that blood in the abdomen. So the next question I think to answer here is, okay, we start off our massive transfusion protocol on these patients, right? I like that 1-1-1 look and try to stay ahead of that hemoglobin curve. Try to stay at least 2 units ahead. But if you're giving 2 units of blood, try to give 2 of FFP, 2 of platelets, and then again, check that fibrinogen, and if it's low, give cryo. The next thing you have to think about is that these patients are often on a heparin infusion. After they've been in the cardiac cath lab, they're most likely receiving heparin, whether it be a bolus or they're on an infusion at this point in time. And so generally we want to reverse that anticoagulation because it can continue to cause anticoagulation for a decent amount of time. So it would be best to give something like protamine sulfate, which is going to be most commonly for the heparin patients that are receiving. So that would be something to consider. The next thing is, after we've given them some hemodynamic support with fluid, pressors, we've done the massive transfusion protocol, we've reversed their anticoagulation, we want to get a hold of surgery and IR. And that's why we got that CTA, because what's going to happen is surgery and IR are going to have an interplay and talk between one another, and they're going to decide what's best for this patient. Generally, IR is going to be the first thing that we want to do. So we want to take them to IR, stick, again, another catheter into those vessels, and then light them up with contrast to see, okay, where is the bleed occurring? And then what they'll do is they'll actually utilize that as a guide to say, I'm going to put a coil embo into that vessel that's actually ruptured or that has been, injured or hit in some type of way during the catheterization process, or they may go in and put a covered stent there. Generally, if the patient is, they've done this, they're not still responding after they've gotten their coil embo or a stent, usually the last thing is they have to open that belly up and go in vascularly. So you don't want to have to do that, but generally that's the last case scenario. I hope that made sense, guys. So that's our RP bleed. Again, definitely one to get on top of very, very quickly. All right, so the next one that you want to be thankful if you ever see it is the post in Mi Pericarditis. So generally there's 2 types. There's one called a Peri Infarction, pericarditis, also known as PIP, and then Dressler syndrome, and we're going to denote that as DS. Generally, the nice thing to look at is the time frame. Generally, if they have, it's like 1 to 3 days post MI, and most likely is the PIP. And if it's like 2 weeks to like months past their MI, it's most likely Dressler syndrome. The key thing behind this one is that these patients typically, after they've had their MI, they'll present with that classic pleuritic chest pain. And so pleuritic chest pain meaning what? What does that mean for it to be pleuritic? Because this is one of the things that you want to be listening to and asking them whenever they're saying, I have chest pain. What is the kind of telltale sign that they have pleuritic chest pain? What do you guys think? What is that kind of indication for pleuritic chest pain? Oh, this is definitely pleuritic chest pain. It is pain that occurs during... What do you guys think? Hey, Katron. So it's usually a type of chest pain that occurs during inspiration. Okay, yep, and so it came in a little bit afterwards. So yeah, innocent, and then Atlantic, and a couple other people have pain with breathing. Yeah, so it's usually some type of inspiratory chest pain, because what happens is when you take a breath in, the lungs expand. When they expand, they actually can kind of compress onto the heart, and that pericardium is really inflamed and agitated at that point in time. So whenever the lungs kind of squeeze on that pericardial area, it can cause some precipitation of pain. Generally, their pain radiates that they have. It's usually substernal and radiates to the trapezius ridge. That's a common presentation. And then generally it gets better when you have them leaning forward, and gets worse when they're laying back on their back supine, because then the diaphragm is kind of pushing up against the pericardial apex, and that's going to cause some pain as well. Generally, they may have some low-grade fevers, and so that's another particular thing to be thinking about as well. So again, the common thing is look at the presentation. They're saying that they have chest pain. Does it hurt during inspiration? Does it hurt whenever they're laying supine? Is it better when they lean forward? Do they have a low-grade fever? Does the pain radiate to the trapezius ridge? And is the pain more sharp and kind of like stabbing type of pain? Okay. All right, once we've kind of said, okay, I think this is more of that type of presentation, what are some ways that we actually diagnose pericarditis? Pericarditis has to have 4 diagnostic criteria. So you have to have that classic pleuritic chest pain. You have to have potentially a friction rub. So that's a nice diagnostic tool as well. So hearing that friction rub is definitely a positive sign that you can potentially say that there's pericarditis. And usually that's a triphasic heart sound that you can hear during atrial systole, ventricular systole, and diastole. You want to look for their EKG. Do they have diffuse ST segment elevation with PR segment depression? And does their echo show a new or worsening type of effusion? Those are all potential signs of someone having a pericarditis. And then once you do that, you just treat them. You treat them with high-dose aspirin. Generally, you give them like 750 to a gram. I prefer the gram Q6 8 hours. And then usually, because I'm giving them all of these NSAIDs, it's preferable to kind of give them something that's going to have some type of gastroprotective nature from ulcers. And so generally, I'll put them on something like Protonix, generally 40 milligrams of Protonix IV. Okay, or you can do PO, it doesn't really matter. Colchicine, I utilize that just as an add-on to reduce any types of recurrences of chest pain. And then if the effusion is greater than 1 centimeter or it's getting bigger subsequently, I will hold on to anticoagulation for the worry that this could convert into a hemorrhagic pericardial effusion. And so those are things to consider on these patients. Okay, what's the difference between the pain in pericarditis and myocarditis? Well, generally myocarditis, again, with those kinds of patients, again, when you think about it, pericarditis is usually most commonly viral. But again, in this situation, it's post-MI, so it's usually inflammatory in this situation. But with myocarditis, usually in those kinds of patients, again, myocarditis-wise, again, it's usually viral as well. You can get some kind of myocarditis during the actual, anginal events, but usually it's a little bit different in these kinds of situations. Classic signs of myocarditis is sometimes you may get, some type of like systolic dysfunction that may present with like an S4 heart sound, S3 heart sound. You may have some type of ST segment elevation on their EKG, but usually with them, their troponin markers may be a little bit elevated. It's a little bit more difficult to diagnose. Generally, you're going to have to kind of send them to cath and just make sure that that vessel is patent, that they don't have any kind of active reinfarction. Ultrasound, yeah, so I use ultrasound. Again, pericarditis, echo, pretty much it's the same thing as an ultrasound. You're just taking a look over the heart, look to see if you see new or any worsening effusion on these patients. Okay? All right, so again, that's kind of what I would do here. So again, retroperitoneal hematoma, next one, post-MI pericarditis, and again, you can really easily differentiate them based upon their clinical presentation. So just be at the bedside. Don't Diagnose images, don't treat labs, don't treat images, don't treat what other people are saying. You need to go in and take a look at the patient and see what they look like. Take a listen to them. Put your hands on them, feel them, look at them, all of that things, okay? So in these, it's simply just going to the bedside and looking at their vitals and saying, okay, they're hypotensive, they're tachycardic, they look pale, they look cool, they look not well perfused, their hemoglobin's dropping, they're having a palpable hematoma, pain upon palpation. I think it's an RP bleed. I'm going in there, I'm asking, hey, what's your chest pain feel like? Oh, it's sharp. It's definitely hurts when I take a breath in. It hurts when I lay flat. It feels better when I lean forward. And generally, it's usually they have like a low-grade fever. So a lot of these things can be easily diagnosed by the clinical exam, but utilize your other tools, such as in the retroperitoneal hematoma, CT angio, whereas if it's a post-Mi Pericarditis, you honestly could do this clinically. If you want to add on the echo may help you to look for a new or worsening infusion. And that's also going to be important because if the effusion has gotten a little bit bigger quickly or it's greater than a centimeter, I may want to hold any anticoagulation on these patients for the worrisome finding of them having a conversion of that into a hemopericardium. Okay. All right, and we can difference the EKG by smile and saturate. Yeah, it's definitely a little tough sometimes, but yeah, I agree. Kind of looking for that concave appearance of the ST segment elevation is nice in these patients. They will have cardiac enzyme elevation though, so I would be careful with kind of saying that troponins would be the differentiating factor. A lot of things can elevate troponins, and so can pericarditis. So I would kind of not depend upon troponin levels. Plus, they've had an MI. So troponin levels are going to stay elevated potentially for up to a week, maybe even a little bit longer. So troponin levels won't be very, very helpful on these patients. All right, so this is the one that's really, really tough. To be honest with you, a lot of the time when a patient comes back, they've had an MI, one of the constant things that we always think about is, are they reinfarcting? And it's really, really difficult. Honestly, it's really difficult to diagnose. And oftentimes they may have to go back to cath. So generally, one of the more common causes of someone reinfarcting is they've likely had a stent. Okay, that's been placed in for one of the vessels that are occluded. So Amy Reeds asked about, what about corticosteroids for pericarditis? So that's a good question. So corticosteroids have actually been shown, according to the literature, to potentially increase the risk of recurrence in patients that do not have underlying uremia or autoimmune diseases. And so generally we try to, or actually, there's one other case I'll mention in a second, but generally corticosteroids, their literature actually is shown to increase the recurrence rates. The only time it's actually been shown to decrease the recurrence rate is in patients with tuberculosis. But generally, the only time we'll give corticosteroids is if we have a patient who has a contraindication to being on NSAIDs. So they have like severe renal failure. They're end-stage renal disease. They have a peptic ulcer disease that's really bad. Those are generally indications of why you would maybe consider corticosteroids. The other indication is if they have uremia. Sometimes it's been seen to be beneficial. And again, going back to that, if a patient is uremic, it's unlikely that they should be on a type of NSAID. And then the other situation is autoimmune diseases, because usually that's inflammatory in nature. And if you give them a steroid, it may reduce the inflammation, but eventually they're going to need to be on long-term immunosuppressants. And so that's why we kind of stay away from steroids for these patients with pericarditis. All right, but again, going back to this, reinfarction is a concerning thing because it's really, really tough. And so generally the most common cause of this is kind of an in-stent thrombosis. So usually you have a stent that you put into whatever vessel that was occluded that caused their MI, and then that stent can actually thrombose. It sometimes can happen. It can happen very, very quickly to the point where they can become acutely and hemodynamically unstable and complain of a very, very severe and new onset chest pain. That's kind of the big thing. A lot of conditions can present with this anginal chest pain after they've had an MI, and sometimes they can have just like a continuous recurrent chest pain even after their procedure. But generally, this one occurs a little bit early too. And so generally when they come in, they come back to the ICU, maybe they've been there for over a day or 2 days, and all of a sudden they complain of this new onset anginal chest pain. You have to think, okay, is this pericarditis? I obviously know the things that will point to pericarditis. So I got to go back and think about the things, the typical type of chest pain, the friction rub, the echo, the EKG findings. The PE is a little bit tough as well. So what would you do for this one? For a PE, I would obviously want to consider, okay, could it be a PE? It definitely could. I could send them to get a CTPA, but what I should actually do is take a look at that ultrasound, that echo, and take a look at their heart. Do I see any new right ventricular dilation or dysfunction? I could take a look at an EKG to see if I see any right heart strain patterns. And these may be helpful signs. But the last thing is I want to think, is it actually an MI, like a type 1 MI that's due to an occlusion? Or is this due to a type 2? That's actually most likely a demand ischemia. So there's some other kind of aggravating factor that's causing this new onset chest pain. Maybe they still have a little bit of an occlusion here. They still have reduced flow through whatever the vessel may be. Maybe it's a little bit occluded, but there's something else that's causing a higher oxygen demand. Maybe their heart's having to pump harder because they're hypotensive. Maybe they're not getting enough oxygen being delivered to their cells, and so they're anemic. Maybe they're hemorrhaging. Maybe they have some type of tachycardia. There's a higher demand which is causing their heart to require more oxygen. That oxygen is not being supplied. And so these are difficult things to differentiate. And again, even getting an EKG on these patients, looking for new ischemic changes, it's tough because sometimes ST segment elevation can persist for a little bit. You can have these Q waves that are there. And so it's really difficult sometimes to say, is this a new ischemic change? Or is this kind of just the progression of their previous MI? What I like to look at is I like to look at their old EKG. So I look at their old EKG and I say, okay, here's where they were having these particular ST segment elevations. Here's where they were having these T-wave inversions. And if I look and I see any new signs, so I see new ST segment elevation in different areas. I see new Q waves. I see new T-wave inversion. I'm going to start thinking, okay, or hyperacute T waves. I'm going to start being a little bit more concerned for some type of ischemic change because their EKG supports a new finding. The other thing is troponins don't really help me here because usually they're still elevated, and that's not going to be helpful because if the troponins are still elevated, that's not going to tell me that there's a new MI. And so because of that, sometimes the literature actually does not support this super well, but you can check something called a CKMB. Sometimes the CKMB, it normalizes quicker than the troponin does. So if you're reinfarcting, your CKMB will actually kind of peak back up. And so sometimes if you're checking the troponins and it's still elevated, you're like, oh, dang, they got these new ischemic changes in their EKG. Troponins are still elevated, and I don't really know. You check the CKMB, it could be elevated. Okay, that's a little bit helpful. What I really depend upon is my EKG and my echo. So I look at my EKG if I have new ischemic changes, and I look at my echo, and I know what they already had. They had, like, let's say that they had a septal infarct. Then I know that there's going to be a septal motion, like abnormality. But if all of a sudden they start having, anterior wall motion abnormalities, and their new EKG is suggesting some type of new ischemia within their anterior wall, I'm going to be a little bit more concerned for a new type of MI or a reinfarction, a new instant thrombosis or occlusion. And so in those situations, I'll send them right to cath. If I find new ischemic changes on their EKG and I have an echo that supports that kind of wall motion abnormality that's new and not present on their previous echo, I think that's enough to be able to kind of support the reason to send them back to the cath lab and make sure that there isn't a vessel that's actually thrombosed or a new vessel that occluded. Okay. So someone said D-dimers maybe. So D-dimers aren't very helpful. I know that a lot of the times the textbooks will say that we should check D-dimers on patients with PEs and stuff like that, but a lot of things can actually elevate your D-dimer. And so they're not very, very helpful. So I guess my question to you is, you got a D-dimer and it was elevated. What would you think? Would you think it's a PE? Would you think it's an MI? A lot of things can actually be elevated. So it wouldn't really tell me what's actually going on if I got a D-dimer, because D-dimers can be elevated in a lot of different conditions. So again, a lot of the times they'll say, you have a low pretest probability for a PE, check a D-dimer. I wouldn't recommend that, honestly. I would just, take into consideration looking at their exam, looking at that EKG, looking at that echo. I would not do a D-dimer in a patient who just had an MI. It's likely that it's going to be elevated. And so I would kind of not check a D-dimer. I really don't ever check a D-dimer. Generally, if I have any concern for a PE, I just send them to get a CTPA. Okay. Let me see. EKG is enough. Sahil said, EKG is good, but again, I like to couple that with the echo. I think it's a good combo to have an EKG that says, okay, you have new ST segment elevation, new T-wave inversion, new hyperacute T waves, new Q waves in this area that wasn't there prior on the previous EKG. Get your echo. So for example, let's say that they had previous ST segment elevation of V1 and V2 and V3. Right? And then all of a sudden, their EKG shows new changes and they have ST segment elevation in 1, AVL, V5, and V6. Well, I'm going to slap the echo on that heart and take a look and see if I see any lateral left ventricular wall motion abnormality, that it's not actually contracting as properly as it should. And if I do have a wall motion abnormality in that lateral wall, and I have new findings on their EKG that suggest a new lateral wall MI, I'm going to be concerned that they re-occluded their LAD and they're occluding blood flow, that distal LAD more particularly, and I'm not getting blood flow there. And so in that situation, I would send them to cath. Okay. All right, cool. So again, I know you guys are asking about a lot of the different markers. The markers aren't really going to help you, to be honest with you. I would not depend upon any kind of troponin, any kind of CKMB, any kind of myoglobin, any kind of AST. These are not going to be very helpful for you. I just really don't think that they're going to give you much information. They're not very specific at all. So I really wouldn't kind of waste your time getting any troponins, CKMB, myoglobin, AST. I would kind of use your EKG and echo. Alrighty. So, hi, Aaron Kellington, hi Zach, on your website, the notes over. Oh, okay, thank you. I'll make sure that gets fixed. So pericarditis and pulmonary effusion, it should be pericardial effusion. Thanks, Aaron. I'll make sure that gets fixed. I appreciate that. Sorry about that. All right, here we go. Let's keep going. All right, so we got the reinfarction. Now we're going to the papillary muscle rupture. So these are a little bit more tougher. So now we're a little bit more tougher. They're a little tougher. So in the patients who have, we've already talked about the retroperitoneal bleed. We talked about the patients with pericarditis. We talked about the reinfarction. So the next one is papillary muscle rupture. So these are getting into your mechanical complications. So how do I know if a patient is experiencing a mechanical complication? So usually this is in that 3 to 14 day range after having an MI. So if they're in the 3 to 14 day range and they're complaining of, generally maybe some type of like dyspnea, so shortness of breath. That's a kind of big thing to think about. So, because what happens is if you think that a patient has a papillary muscle rupture, so let's say they're in the 3 to 14 day range post-MI, and they had an inferior or posterior MI. These are things to think about. So if they had an inferior posterior MI, these are things to think about. After you've had an inferior posterior MI, you particularly affect the papillary muscles of the posterior medial portion of the left ventricle. So the posterior medial papillary muscle of the left ventricle usually gets hit the hardest during inferior and posterior MIs. What happens is if that muscle actually infarcts, and whenever it actually ruptures off of the actual left ventricular wall, now it can't hold on to those chordae tendineae tightly, and they're just like bouncing around all over the place. And so what happens is that posterior leaflet of the mitral valve may start bowing into the left atrium, especially during systole, and actually cause blood jets to get pushed back into the left atrium during ventricular systole. And so again, I would be very, very mindful of this if a patient has posterior inferior MI, and all of a sudden they're complaining of shortness of breath and their blood pressure is on a little bit of the softer side. So again, 3 to 14 days, history of a posterior inferior MI, come into the ICU, they're in the ICU, they're in the hospital floor, and all of a sudden they're complaining of shortness of breath and their blood pressure is on the softer end. What I will do is I'll go ahead and I'll listen to their heart. When I listen to their heart, what am I listening for? I'm listening for a potential murmur, a mitral regurgitation murmur that may be indicative of a papillary muscle rupture. And so this may be a holosystolic murmur that I'll hear on that left sternal border, maybe radiating into like the axillary area. Okay? Once I've done that, I'll order a chest x-ray. Whenever anybody times someone's dyspneic, it's never a bad idea to order a chest x-ray and an EKG. Usually I'll do that EKG to make sure that there's no other complications going on post-MI, such as, again, pericarditis, a reinfarction, anything of that nature. So once I've done that, and any kind of arrhythmias as well. So I'll get the chest x-ray because if they're short of breath, I'm concerned potentially about a pulmonary edema, right? If someone has an acute onset mitral regurgitation, what happens is that blood jet that's coming from the left ventricle gets pushed back into the left atrium. And so the left atrium starts kind of getting overfilled and volume overloaded. And so what happens is blood starts kind of backing up into the pulmonary venous system, and that can lead to pulmonary edema, which will produce this shortness of breath. Also, if they are having hypotension, it's likely because that left ventricle, every time it's contracting blood to get pushed out of the left ventricle into the aorta, it's actually less of that volume is going out into the aorta, and maybe let's say some of it's actually going back into the left atrium. And so technically their stroke volume is dropping, which will drop their cardiac output and effectively drop their blood pressure. What I like to do is I like to go into the room really quickly and grab the ultrasound, put it over their lungs. If I see B lines, that's obviously diagnostic of higher pulmonary capillary wedge pressure, higher likelihood of this being pulmonary edema. The next thing I'll do is I'll throw the echo onto their heart, and I'll look at their heart in the parasternal long axis view, and I'll throw on color Doppler. And what I look for is I look for a blood jet to be moving from the left ventricle into the left atrium during the systolic process of the ventricles. And if I throw it on M mode, I have a high likelihood of them having some type of mitral regurgitation. And so those are big things to be thinking about, okay? So again, coming to the patient who is a posterior MI, inferior MI, they're about 3 to 14 days post-MI. They're complaining of dyspnea, shortness of breath. Their blood pressure is a little on the softer side. A new onset mitral regurgitation murmur. I throw an ultrasound over the lungs. I see B lines. Throw it over their heart. I see a mitral regurgitation jet that's occurring during the ventricular systole. When I do that, I obviously can get a chest x-ray to support the pulmonary edema, but I don't need it. I can usually use my ultrasound to see these things. Once I've done that, I then have a very high likelihood that this patient had a papillary muscle rupture. What I will do for these patients is, in their goal to treat them, is to really reduce their afterload, because what I want to do is reduce the afterload to where the blood that the left ventricle is pumping is going right out into the aorta as much as possible. So if I drop the pressure within the actual the aorta, it'll make the systemic pressure gradient a lot easier for blood to flow easily from the left ventricle into the aorta. The problem is that when you dilate some of those vessels of the systemic artery system, you can drop their blood pressure, right? Because you drop their systemic vascular resistance. And so sometimes what I will do is I'll put them on a high dose nitroglycerin drip, and that's going to help to really reduce their afterload. And I'll throw in a little bit of a norepinephrine drip, a Levofed drip, to kind of support a small amount of systemic vascular resistance so that their blood pressure can tolerate this, because they're going to be hypotensive. And so what I'll do is I'll throw in a high dose nitroglycerin drip that's going to give me a little bit of vasodilation to increase my pressure gradient across the left ventricle into the aorta. And then I'll throw in just a teensy bit of Levofed to support and counteract the hypotension that may be coming with the high dose nitroglycerin. Generally, the other thing I may do is, if I'm having them on this nitroglycerin drip, I may pick something like Levofed, or I may put them on an inotrope. Generally, the problem, though, is when I put them on an inotrope, I might consider something like epinephrine, because it's a good inotrope and it also gives you good systemic vascular resistance. If I pick something like dobutamine, if I pick something like milrinone, that'll also drop their pressure in combination with nitroglycerin. So I would not try to give something like that unless I had another pressor on board. So, for example, if I put them on nitroglycerin drip, norepinephrine drip, I may also throw them on dobutamine as well, because the dobutamine will, again, potentially give them more kick to their ventricles, but again, it can drop their pressure because it vasodilates them as well. So generally, that's what I'll start off with, is afterload reduction with a nitroglycerin drip, Levofed, and an inotrope as well. Intra-aortic balloon pumps could be good as a bridge to surgery, but please, for the love of goodness, don't delay a surgery to put in a balloon pump. Okay. Generally, for these patients, afterload reduction is good enough with the high dose nitro, giving the Levofed along with an inotrope, and then generally get them to surgery to get some type of mitral valve replacement or mitral valve, like repair of some type. Okay. So Sahil Khan said epinephrine will increase output. Yep. So that's what I'm saying. Generally, if these patients, if I had it, again, it kind of depends. You have to take into consideration everything. So if I have a patient who's super, super tachycardic, I may want to be careful with giving them something like epinephrine. So that's something I would consider for these patients is, again, take a look at their entire heart. Generally, if they have a lower EF, it may be beneficial to put them on something like epinephrine. But again, you're going to be giving them the dobutamine in the meantime to be able to help out with that process. So high dose nitroglycerin will help you to get a little bit of that, again, vasodilatory effect, which is going to help with afterload reduction, but it can drop your pressure. And so generally you want to give some type of inopressor, something that's going to give you a little bit of contraction of the left ventricle, as well as give you a little bit of systemic vascular resistance so that you don't actually drop their pressure significantly with the nitro. And so generally I prefer Levofed. You can't go wrong with it, but you can't consider something like epinephrine if their heart rate can tolerate it. If they're like tacking away at like 160, 150, I probably wouldn't put them on an epinephrine infusion because you might put them into a Vtec. So I would probably stay away from something like that. But I'll put them on something like Levofed and then maybe consider something like dobutamine. But stay away from a balloon pump. If all possible, if you absolutely need it, put it in. But don't delay it until you can get that surgery. Okay? Alrighty. Alright, what about that VSD, baby? Furosemide is not good for pulmonary edema. You can consider furosemide. Definitely. I would consider it. Generally, for these patients, I would try maybe other things to reduce a little bit of their pulmonary edema. Furosemide in these patients, you definitely can consider it. You just want to be careful with their pressure being kind of like more hemodynamically tenuous. If I gave someone furosemide, the potential concern here is that I could actually drop their total intravascular, effective arterial blood volume. They may get good diuresis, they may get improvement in pulmonary edema. What I may actually do instead to help these patients out is I may put them on something like BiPAP. because BiPAP is good for cardiogenic pulmonary edema. I can consider Lasix once their hemodynamics are a little bit more stable. But I probably would try something like BiPAP in the interim to get more of that cardiogenic pulmonary edema kind of pushed out of the interstitial spaces, but giving them more PEEP. So that's what I would consider. Okay. Ventricular septal defect is the next one to consider for these patients. So thiazide is good. Again, I would probably stay away from any kind of diuretics at this point in time. I would give them some PEEP with BiPAP, and once they become a little bit more hemodynamically stable, you can consider adding on some Lasix PRN whenever they need it. Okay? All right, ventricular septal defects for these patients. So we've got the papillary muscle rupture, right? That was concerning when you have the posterior inferior MIs, all right? Obviously, pulmonary edema, so they can present with shortness of breath. They can also present with... Is IV albumin a good way to combat that? So I'm not there's no literature in HA to say that albumin is good for these patients that you're diuresing. The only times that albumin has actually been shown to be beneficial as a supplementation for patients that you're trying to increase like intravascular volume or those kinds of scenarios is a patient with like severe liver failure. So they have like what's called hepatorenal syndrome. The other condition would be something like if they have nephrotic syndrome. Those would kind of be the only kind of scenarios truly where albumin may be somewhat beneficial that I am aware of. There was studies that looked at IV albumin in patients who were in a shocky state, or that you're trying to diurese them with giving albumin, and the whole thought process behind giving albumin is that you're going to pull fluid from the extravascular space into the intravascular and use that fluid that you're pulling in to diurese off. There's been no data that actually suggests any superiority of that. And in fact, usually just giving Lasix on its own is just as effective, if not more effective, than giving albumin and Lasix. So, there's no kind of defining parameters that really show much benefit to that. Good question, though. So the next one is the VSD, the ventricular septal defect. When you give these patients the consideration of, okay, they're coming back to the ICU, they have a very large anterior MI, right? They got that anterior MI in comparison to the posterior inferior MI. One of the big things is think about everything that kind of happened with those patients who had the papillary muscle rupture. But this one is, again, they're going to present with some type of a shortness of breath, right? So it kind of presents similar to the papillary muscle rupture in the same time period as well. VSDs, they can happen. They're relatively rare, but definitely something to think about. So if I have a patient who's presenting with a new onset shortness of breath, and you guys really want to diurese these guys, mannitol, thiazides, Lasix, albumin. There's differences in practices. Everybody can try their things that they want to do. Evidence-based wise, I don't think there's anything to support giving somebody diuresis of mannitol, thiazides, or albumin. Lasix, I'm okay with. I would just do it if their hemodynamics actually can support that. I wouldn't be blasting them with, mannitol, thiazides, or giving them IV albumin. I would consider diuresing them if their hemodynamics can tolerate it and put them on BiPAP. BiPAP's going to get them stable with that cardiogenic pulmonary edema getting pushed out with the PEEP, but generally I would kind of hold off on doing any kind of diuresis until I get them a little bit more hemodynamically stable, and then I would give them something like 80, 100 Lasix, something like that, to pull off some of that fluid. Okay. All right, so again, VSD, got a patient, large anterior MI. So that's something to think about. 3 to 14 days post-MI, they got a big anterior MI in comparison to a posterior inferior MI with papillary muscle rupture. Once I've done that, I think, okay, they got new onset shortness of breath, pulmonary edema, their blood pressure is a little bit softer, right? And usually it's pretty quick, where their blood pressure actually gets a little bit more they get more hypotensive. And it's because you're shifting a lot of the blood from the left ventricle into the right ventricle. And so when you do that, you obviously drop your cardiac output, stroke volume, cardiac output, blood pressure. So again, with these patients, they're going to present very, very similarly to that papillary muscle rupture. They're also going to complain of some chest pain. The big difference here is that, again, when you're going and you're listening to their heart again, you stand by the bedside. So they're coming in and say, hey, the patient's having some chest pain. Their blood pressure's a little bit softer. They're complaining of shortness of breath. I go in the same way I did with the papillary muscle rupture. Grab my echo, put it over the lungs. Do I see B lines? They may have some B lines. So that's one thing to see, is they may have some curly B lines that are present on their ultrasound, indicative of pulmonary edema. Next thing is I'll throw the ultrasound probe over that heart, and I'll look to see what do I see during the actual process. I'll throw in color Doppler. I'll look at that parasternal long axis view and see if I see any blood jet that's going from the left ventricle to the left atrium. If I do not see that, highly unlikely that they have some type of papillary muscle rupture that's causing the mitral regurgitation. I keep it in that parasternal long axis view, and I look to see if I see any jet of blood that's moving from the left ventricle into the right ventricle. If I don't see it very well, then I'll take my probe and I'll go into what's called an apical 4-chamber view and put on that color Doppler and look to see ventricle. You're going to get more volume into the right ventricle. So the right ventricle chamber may be a little bit bigger, so it may be dilated. And so that's an interesting thing to see. And so what I'll do is I grab the ultrasound, put it over the lungs. They got B lines. Put over the long axis view, look to see if I see a jet murmur via mitral regurg. If I don't see that, I keep it in parasternal long to see if I see any blood jet from the left ventricle to the right ventricle. If I don't see it very well, I throw on apical 4-chamber. If I see that jet of blood and I get a good view of the right ventricle into the left ventricle, and I see the right ventricle is likely a VSD. And so those are really quick ways. And so that's why I'm a big fan of ultrasound. You can pick up a lot of things very, very quickly. If they have a central line in, sometimes, or a PA catheter, you can suck some of that blood from that right ventricle or pulmonary artery area. And sometimes the oxygenated blood may be a little bit higher on that side. So sometimes if I put in a central line, I may suck some blood from that right ventricle and just send off what's called the SCVO2 and look to see if it's a little bit in higher concentration. Normatic, I admire you. But yeah, that's kind of the things that I would do for this patient. Okay, so we have an obvious quick approach for these patients. And again, they're going to have a murmur, but one of the big things is it may sound similar to a patient with a papillary muscle rupture. Okay, so treatment-wise, it's the same exact question. It's the same exact answer. We're going to afterload reduce, right? So we got to afterload reduce because we want to drop some of the systemic vascular resistance within the aortic system. So that way we have a higher pressure gradient. So blood will quickly flow from the left ventricle into the aorta. So it can go through the pressure of least resistance, the path of least resistance. And so we'll do the high dose nitro, throw on top of that the Levophed to support their hemodynamics, and consider an inotrope. You can do the balloon pump, but don't hold that until they get surgery. Get them to surgery as quickly as possible where they can surgically close it, or sometimes they may float a catheter down through the actual right atrium, right ventricle, and put it across the ventricular septal defect and then pull backwards through the transcatheter closure. And so sometimes you can do that as well. One thing I would very, very likely consider is, again, going back to that pulmonary edema. Again, you can diurese them if their hemodynamics support it. I would try not to do that. I would support them with BiPAP because they're going to get that positive airway pressure that will push some of the fluid out of that interstitial spaces. For the love of goodness, don't intubate them though. If you intubate these patients and they're already hypotensive and you induce them with something like propofol, and then you also paralyze them, you take away some of their intrathoracic pressure. So first thing you do is you induce them with propofol. That drops their pressure. The second thing is that you also paralyze them and you take away their ability to breathe, which generates their intrathoracic pressure gradients to suck blood into the right side of the heart to increase their actual stroke volume. And so by doing that, you potentially put them in a high risk of becoming hypotensive and to the point where they can actually go into cardiac arrest. And so for these patients, I would afterload reduce, high dose nitro, Levophed to support the pressure, consider an inotrope, balloon pump, if they're not going to surgery anytime soon, but get them to surgery, surgically close it, or they can go to IR and do an IR transcatheter closure. Do not intubate them. If you have to, you can consider it. Try to induce them with something else, such as like ketamine or Versed, but don't do propofol and try to hold that off. Okay? I hope that makes sense. Okay. The next one, this one's scary. I've seen it once. Nearly pooped my Huggies. It's a scary condition. Usually these patients don't usually live. Pretty likely, yeah. Worst case, you would use induction. I prefer ketamine. I think ketamine's a little bit more hemodynamically stable. So generally, if I'm going to induce somebody, the best kind of scenario that I would consider is I'll hit them with rocuronium first, generally somewhere around like 0.6 to 1 mg per kg, and then I'll hit them with ketamine, 2 milligrams per kilogram IV, and then maybe if I got the tube down already, I'll throw in 5 milligrams of Versed for a little extra sedation. Okay, that's generally how I would induce to kind of reduce any kind of like hemodynamic collapse during that time period. So I call it the Rocetium Roketamine. Yeah, roketamine. Rocuronium and ketamine is kind of a good induction agent. All right, so ventricular wall rupture. This one's a scary one. Usually the left ventricle just explodes and just pours blood into their pericardial cavity. So it's usually a big anterior MI. So they've got a big anterior MI, usually like anterior lateral. So they're definitely involving a lot of their left wall. And so if they're getting more of that lateral wall, it's definitely distal LAD and then left circumflex. And so one of the biggest risk factors is that they had a long time before they reperfused them. So before they got to PCI, before they got thrombolysis, before they got a cabbage, whatever it may be, it was a long time before they reperfused. And so I saw this once with a patient who had a massive LAD. They ended up getting a TPA because they also had a stroke. And then they got a heparin infusion, went to cath. It was a little bit longer because they got the TPA and they had to it was just a long kind of journey. And what happened is they ended up having a rupture of their left ventricular free wall. And whenever they ruptured, they went into this acute onset cardiac tamponade to where their blood pressure dropped precipitously, very, very quickly. And they went into cardiac arrest, particularly pulseless electrical activity. And so we started CPR. During the CPR, I obviously did my exam. We're starting our CPR. I grab my echo, I throw it in the subxiphoid view, and I see a massive hemopericardium with physiology of cardiac tamponade. It was too late. We tried to do a pericardiocentesis, but it was already too late. The patient unfortunately succumbed to their illness. So generally, whenever you see a person with a ventricular free wall rupture, this is one that you want to act on extremely quickly. So again, they have a patient who has had a large anterior MI, usually distal LAD, left circumflex occlusion. They got a late reperfusion. They all of a sudden have an acute hemodynamic collapse where they become extremely hypotensive, extremely tachycardic. They have decreased heart sounds when you're listening to them, or they go into immediate cardiac arrest, PEA. In these patients, it's important to obviously, if they're going into PEA arrest, you start ACLS. So you'll start your compressions and you'll get ready to deliver your medications. But if you can throw on an EKG, you want to see if you can see any types of findings here. Usually it's not super helpful. What I like to do is, again, as we're doing CPR and we're taking our little breaks in between pushing epi and continuing our compressions, I'll grab my ultrasound, quickly throw it in the subxiphoid view, look to see what I see. And in these cases, I'll usually see a massive effusion. And I'll throw on quick color Doppler to see if I see any contrast. If I see any Doppler jet flow from the left ventricle into the pericardial cavity. If I have time and they're hemodynamically stable, sometimes I can give I can do a contrast echo where they push contrast into the vein, and then I'll be able to see that flow or extravasation of the contrast into the pericardial cavity. Usually these patients aren't usually stable enough for me to do that. So usually it's effusion, color Doppler looking for that flow. If they are a little bit more hemodynamically stable, I'll have them push the contrast and look for that contrast to flow into the pericardial cavity. Generally, once I've seen massive effusion, tamponade physiology. So tamponade physiology is you would have to have collapse of the right atrium, the right ventricle during diastole, plethoric IVC, and then a lot of changes in their flow across their tricuspid valve during inspiration. We call it respirophasic changes. But once I see something like that, I usually would grab a pericardiocentesis kit and tap usually into the pericardial cavity in a peristernal long axis view. Suck some of that blood off. Usually it's going to rapidly reaccumulate, so that's when surgery comes in and saves me and puts in a drain via pericardial window. But in these patients, generally the best thing to do for them is to drain the fluid. Usually it provides a small improvement in their hemodynamics. But again, if it's a massive bleed like this, like a ventricular free wall rupture, it'll just reaccumulate again. So you have to put in a drain and then generally get them into surgery as soon as possible so you can repair that left ventricular wall rupture. You can try things like IV fluids and inotropes and pressors to support their hemodynamics. But again, the best thing to do is a pericardiocentesis. But again, it's going to rapidly reaccumulate, so they need to get to surgery, maybe throw in a drain, and then repair that rupture. Okay, these are usually the ones that they don't usually do well. Very high mortality rate. I think it's like in the 90% range. All right, so this is another one. So Vtec, VFib, this is another one that you can see. Usually it's in the first 24 hours after an MI. So when someone's had an MI, sometimes you can get these things called non-sustained Vtec. So non-sustained Vtec is it's usually like there's no hemodynamic compromise or collapse, and it's usually less than 30 seconds. Whenever you have sustained VTAC, it's usually greater than 30 seconds, and particularly it's actually causing some hemodynamic changes where they're becoming hypotensive, they're developing pulmonary edema, they're having altered mentation, things of that nature. Generally, what you can look at is you can look at their monitor. Sometimes on their EKG telemetry, you can see that they have wide complex tachycardia with a heart rate greater than 100 beats per minute. You should print off a 12-lead EKG to take a good look at that, though. And if you do see wide complex tachycardia, it's VTAC until proven otherwise, right? That's kind of always the basic assumption is if you see wide complex tachycardia, you assume it's VTAC until proven otherwise. And so in these patients, it's usually wide complex tachycardia lasting greater than 30 seconds or with hemodynamic compromise. So they're hypotensive, altered mentation, pulmonary edema, things of that nature. In any unstable patient who has VTAC, you always shock, right? So you always hit them with electricity. Whenever you do that, if they convert, it's nice because then you can start them on an amiodarone drip. There's also some literature that actually suggests the lidocaine infusion may be good too. And the whole point behind doing those is that you're preventing recurrence for them going back into VTAC. So generally, whenever a patient's unstable, they have this direct current cardioversion, you can throw them on an amiodarone drip or a lidocaine infusion second line. I would go with amiodarone over lidocaine. And then if the amiodarone isn't working or they have a contraindication amiodarone, you can consider something like lidocaine. The other thing is so abutolide. So it sometimes is helpful, but the only risk with abutolide is I think abutolide is good in certain situations like atrial fibrillation. There may be actually some benefit to that. The only thing I would be careful of with abutolide is that there's a high risk of prolonging that QT interval. You can consider it. I probably would try to stay away from abutolide in these situations just because of the risk that it can cause that polymorphic VTAC with a prolonged QT. And increase the risk of torsades de points. So I would kind of go with what's been relatively tried and true. Some people actually consider procainamide, but I like amiodarone infusions. And then again, second line is lidocaine. Avoid beta agonists is another one. So usually in these patients, you don't want to give them any kind of like stimulant such as albuterol. You don't want to give them anything like epinephrine, norepinephrine. Stay away from dobutamine. These are all things that are going to jack their heart rate up even more. And make them more tachycardic. So generally unstable, shock. Okay. After you shock, prevent recurrence with amio or lidocaine. You can consider things like procainamide. Abutolide, I would probably not do that though. Get them off of any kind of infusion that's causing any beta agonism. So if they're on a levofed drip, an epinephrine drip, a dobutamine drip, get them off. Put them on something else that's a little bit more unlikely to cause that tachycardia. And I would check their K and magnesium levels. This is always a good thing to check because sometimes those can cause tachycardia. So check their K, make sure it's greater than at least, some will say 2, greater than 4 to 4.5, and for magnesium, greater than 2. Again, beta blockers, if their blood pressure can tolerate it, may be somewhat beneficial. I would be very careful if they're hemodynamically unstable. I would not be giving any beta blockers. And the other one is any pain and anxiety is going to up their heart rate as well. So I would consider treating their pain, treating their anxiety, considering something like dexmedetomidine, considering something like Ativan. Be careful with the Ativan though. But dexmedetomidine, Ativan, considering anything like fentanyl boluses as well for the pain. But the ultimate goal for these patients is they're likely having another MI, and so sometimes you have to maybe reperfuse. And so one of the things to be very, very cognizant of is that sometimes patients can have a VTAC VFib post-MI within the first 24 hours, or they may potentially be re-occluding, and then again, that's increasing the risk of them having a new onset VTAC VFib, and that can cause this very dangerous situation, deleterious. So I would consider maybe sending them back to make sure that they don't need to be reperfused, and that's why they're going into this VTAC VFib. The big thing to think about is if you ever see a patient with polymorphic VTAC and their QT interval prior to them going into this was prolonged in these cases, you should definitely stop the offending medication, something like abutolide. And maybe give something like magnesium. Magnesium infusion, something like, give them like a 4-gram mag rider and then throw them on an infusion. The other thing is if someone has a polymorphic VTAC with a normal QT prior to them actually going into that polymorphic VTAC, they will likely need reperfusion. It's most likely the reason that they went into this, and so you got to send them back to the cath lab to get that intervention. The question that usually becomes more important to think about is if a patient actually came back from the cath lab about 48 hours ago, they had an MI. Usually, again, these types of Vtec, VFib, they occur within the first 24 hours after someone has an MI. If the Vtec or VFib developed at least 48 hours after they had their MI, or after they're revascularized already, it's likely that these patients are going to need an AICD because they're at high risk for them continuously going into Vtec and VFib because you've already reperfused them, you've already treated them for what their actual cause was, which was the MI. If they're continuously having Vtec and VFib that's sustained, they're at high risk of going into a malignant arrhythmia and then, obviously succumbing to their illness. So usually these patients require an AICD. All right. Chances of sudden cardiac death. Yeah, they're relatively high. High likelihood of sudden cardiac death within these patients of Vtec VFib after an MI, especially within that first 24-hour period. Heart blocks. So this is another one to consider for these patients as well. So heart blocks, definitely you want to be thinking about these in patients who had an inferior MI. Inferior MI definitely has that right coronary artery that supplies the AV node. And so whenever they have a right coronary artery occlusion, particularly again leading to an inferior MI, this can cause an AV block because you're actually causing a lesion of the AV node. And the anterior MIs though, these are particularly going to be more of that left anterior descending artery that is coming down and giving off blood to the septum and giving off blood to the actual lateral wall of the left ventricle. So sometimes you can hit like those bundle branches, the right bundle branch, the left bundle branch, the left anterior and posterior fascicular branches as well. And so generally those will give you more of those bundle branch blocks. Again, inferior MI, so if I have a patient who has concerned findings of an AV block because we actually hit that right coronary artery that occluded, and afterwards it was just enough to actually cause the AV node to dysfunction and actually become ischemic and undergo this kind of AV blockade effect, what it may show is that there is a junctional escape rhythm. So generally this is whenever the kind of like the bundle of His is generally kind of like taking over, right? So whenever these kinds of patients are having this type of rhythm, it's usually that there's no obvious P wave. So there's no obvious P wave in these patients. And what you'll notice is this narrow QRS complex in these patients with a pretty steady heart rate of about 40 to 60 beats per minute. So again, in these inferior MIs, usually it's kind of an AV blockade, which is a junctional escape rhythm. So if I have a patient, I see on telemetry, I see that their heart rates are a little bit lower, 40 to 60, and I see that there's no obvious P waves. And I would be concerned for a junctional escape rhythm, and likely that cause is due to them having some type of AV block due to that right coronary artery occlusion if I knew that they had an inferior MI. And so that's something to consider. Generally in these patients, you can consider atropine. Atropine may help these patients, but generally what I would do is I would give atropine, and if it didn't work, I would go straight to the next thing, which is either considering something like epinephrine or isoproterenol. Epinephrine is pretty good because if they're a little bit more hypotensive, the epinephrine will support that. Isoproterenol is kind of like the gold standard for chronotropic agents. It can probably get a heart rate out of a rock if it needed to. So isoproterenol is a pretty strong agent for chronotropic action. So generally I'll try atropine. If it doesn't work, I'll put them on something like epi or isoproterenol, and I'll have them put the pads on the patient and start transcutaneously pacing them until I can get a kit set up and start floating a wire down into the right ventricle via a transvenous pacer. Okay. So again, those are things to think about, especially if they're becoming more hemodynamically unstable and they have this bad AV block to the point where it's getting to like, second degree Mobitz 2 or third degree AV block. If I see something like that, I'm going to be a little bit more concerned. And again, I'll step to the next step, which is going atropine at the bedside, giving if it needed. If it doesn't, start epi or isoproterenol. If that doesn't work, I'll start transcutaneously pacing and getting ready to float a pacer down. In an anterior MI, these are patients, generally what you'll look at is you see a new left bundle branch block because, again, you hit that LAD, right? And so the LAD wasn't able to supply enough blood flow to the septum. And so you knock out the left bundle branch or you knock out the right bundle branch. And so if I see a new left bundle branch block or I see a new right bundle branch block with what's called a left anterior fascicular block or a left posterior fascicular block, which will change my axis, then I may just resort to a transvenous pacer in these patients as well. But ultimately, they may also need some type of AICD potentially in the long term or potentially some type of pacer in the long term. Okay? But yeah, usually these are some of the complications that you can see. So Dad, I'm having a heart attack. Please call me an ambulance. You're an ambulance. These are Rob's things. He likes to put these on these case studies. They're always cute. But yeah, these are a lot of complications that you can see post MI. I hope it really helped. I hope you guys liked it. Let me look at any questions that came up here. There's a bundle branch equivalent to an ST elevation. I think there was some new literature actually that supported that new left bundle branch blocks are actually not technically considered an ST segment like equivalent anymore. I'll have to look back at that, but from what I believe, I think that if there was some newer literature that actually said that, it's unlikely that, I think they're changing the definition of it, that new left bundle branch blocks are not technically considered to be a STEMI equivalent anymore. Yeah, I'll look into that though. I'll look and see if I can find that, but I believe it was saying something of that nature. Zach, how to read V1, V2, V3 lead. When it comes to those leads, my mind goes upside down. I don't know how to answer that. How to read V1, V2, V3. I don't really have an EKG in front of me to do that, but sorry. So yeah, reading like V1, V2, V3. I guess it depends on what you're looking for. That's kind of I'm sorry, I know it's not a great answer, but it's a very broad question to ask, so I'm not quite sure exactly how to tell you that, because again, it depends on what you're looking for these leads. Generally V1, V2, V3, beneficial leads to look for like an anterior septal MI or some type of posterior MI as well. But also could be good for a lot of the other things, obviously looking for any signs of right bundle branch blocks or any kind of like poor R wave progression and like right ventricular hypertrophy or old left MIs and things like that. So your Spotify podcast name, I think it's just going to be called like the Ninja Nerd Podcast. I don't know. Do you guys think we should call it something else? I think the Ninja Nerd Podcast would be pretty cool. Well, you guys can throw some comments down there. Throw some comments into the video and say what you guys think it should be. We'll take it into consideration. But I think we were just going to go with like Ninja Nerd Podcast. Okay, Ninja Nerd. Rob has spoken. Yeah, any other questions, guys, that you guys may have about this? Again, we'll hopefully get crack-a-lackin' on this podcast, and the first one that we'll start with is cardiac tamponade. So I really, really hope that you guys check it out, and I hope that it's going to be helpful, and I hope it guides you in making good clinical decision making and having logic behind what you do that's backed up by evidence. Yeah, I think at the end of the day, we should be willing to put all of our time in to give our patients the best possible, treatment that we can. They deserve it. And so going and treating based off of evidence-based medicine, I think, is one of the best ways to do that. What's my master's in? Physician assistant studies. You should invite Q into the podcast. Definitely. I think if we do some stuff on like ortho or stuff like that, Q would probably be one of the best ones to ask. What's your job? I work as a ICU physician assistant, like the neurocritical care ICU unit. Well, engineers, I've enjoyed doing these case studies. I'm sorry that they're coming to an end, but I think it's going to be I think it's going to be a better thing to do these podcasts. One of the reasons why is it's going to require more time. I want to make sure that these podcasts that I'm doing are definitely like well written. They definitely give you guys a step-by-step approach into a lot of these complex diseases. They just make you feel more comfortable that when you guys walk in on your first day into the hospital or wherever it may be, and you're dealing with these critically ill patients, that you guys will have a step-by-step process in your head, kind of a rapid thing to refer to, and you'll have evidence-based support behind it. So that's my goal. They may only come like once a month because I'm going to be putting a lot of time into them in the background, prepping, reading through different types of articles, and just making sure that everything I present to you guys is evidence-based. And hopefully we'll have that again there in the podcast and like a show note kind of thing, that if you guys want to go and read or listen to the podcast while going and reviewing the notes, you'll have all the literature and all the articles there to support what we're talking about. So I hope that you guys like this podcast that we're going to do. Thank you guys for being so supportive with these case studies. Thank you for being so awesome and just being so interested and constantly communicating and just being involved in this chat process. I've really enjoyed it. So, Engineers, I really love you. I thank you guys. And as always, until next time.